Hello, and welcome to this Pneumococcal Update 2018. My name is Ouita Gatton, and I will be your presenter for this program. This is a program sponsored by the North Carolina Association of Pharmacists Collaborative. I must disclose that I am a speaker for Merck Vaccines and an instructor for the American Pharmacists Association. So what are our objectives for this program? We need to discuss the risk of pneumococcal disease with a focus on adults with increased risk for developing disease. We then need to discuss strategies pharmacists can use to help prevent pneumococcal disease and increase vaccination rates. Then we need to review North Carolina immunization practice for pharmacists and the proper immunization technique for pneumococcal vaccines. Let's review what is pneumococcal disease. So, how common is pneumococcal disease? Here are some statistics to enhance our understanding of its prevalence. In looking at the clinical burden of community-acquired pneumonia, 27.3% of community-acquired pneumonia, or CAP, cases are caused by strep pneumonia. Other causes account for the remaining 72.7%. Then we can break down the pneumococcal number even more by noting that 24.8% of all pneumococcal pneumonia are considered bacteremic. Non-bacteremic cases represent 75.2%. So why do these numbers matter? Well, our next slide reveals why. If we look at the burden of community-acquired pneumonia, this means 1 in every 4 patients diagnosed with CAP will develop pneumococcal bacteremia. This is a tremendous disease burden on our communities and healthcare system, not to mention the debilitation caused to patients suffering from the disease. Let's dive a little deeper and look at pneumococcal disease itself. It is caused by the bacteria Streptococcus pneumoniae and is a leading cause of vaccine-preventable illness and death in the United States. It's a frequent cause of secondary bacterial pneumonia following flu illness or influenza illness. And our threat for pneumococcal disease is year-round, not just in the winter. And antibiotic resistance is common. I do want to focus on a phrase that is in our second bullet point, vaccine-preventable illness. This will play a very heavy part as we dive deeper into the vaccines for this disease. Also, more than 90 serotypes is based on polysaccharide capsules. And the disseminated disease caused by pneumococcus is bacteremia, meningitis, arthritis, and peritonitis. Our picture here depicts meningitis of the brain caused by a pneumococcal infection. Pneumococcal disease also can spread to our upper respiratory tract in the form of sinusitis and otitis media, and what we commonly know in the lower respiratory tract as pneumonia. This comprehensive slide summarizes for us the progression of the bacteria once it enters the nasal passages. It spreads via the blood vessels and deposits itself along the way in the form of diseases that we have already mentioned. You can see in the brain, in the ear, in our sinuses, in the blood, in our lung, peritoneum, and other vulnerable areas. And none of us are immune to this disease. There are, however, populations at increased risk for pneumococcal disease. What populations are most vulnerable to pneumococcal disease? This slide provides us with a summary of these groups. Of course, the most common one, and the one that we as pharmacists probably think of the most, are those that turn 65 years of age and older. They bring us their Medicare card in, and we automatically think pneumococcal disease, right? However, I would like to challenge us as pharmacists that of particular interest to us should be the chronic disease categories listed on our slide here. Those with diabetes, chronic heart, and chronic lung disease. We will unwrap these disease states a bit more later and see that these patients represent an area where pharmacists can have significant impact on vaccination rates for these patients. Also, special populations such as those with cochlear implants, those with cerebral spinal fluid leaks, any type of immunosuppression, and asplenia require particular pneumococcal vaccination. So what is it about diabetes that causes us to want to pay attention to this group of patients? Well, diabetes in patients with infections have a tendency to develop hyperglycemia. Then hyperglycemia causes an impairment of certain immune cell functions, which then lead to reduced bacterial clearance, thus potentially a pneumococcal infection. How about chronic heart? This includes all related heart disease except high blood pressure. High blood pressure is not considered part of the recommendations for pneumococcal vaccination. Chronic heart disease primarily relates to those with inadequate cardiac output. It can produce lung congestion, which is followed by potentially reduced clearance of bacteria. Then our patient can develop a pneumococcal infection. And not unsimilarly, those with chronic lung disease, and these do include asthma, chronic obstructive pulmonary disease, or COPD, and those that are smokers. These conditions, of course, can lead to chronic lung infection, which creates a reduced clearance of bacteria, and then possibly creating a pneumococcal infection. This slide is a summary of these chronic conditions we've just reviewed, and we know that the risk of pneumococcal disease increases with age and certain chronic conditions, but did we also know that the risk in the ages of our healthy adults listed here, compared with healthy adults listed here, ages 18 to 64, the rate of invasive pneumococcal disease is 3.5 times higher in adults with diabetes, 4.3 times higher in adults with chronic lung disease, with chronic heart disease, and 10 times higher in adults with chronic lung disease. And just as a reminder, we as pharmacists see these patients every single hour, I would suggest, in most of our pharmacy practices, especially those of us that are in more ambulatory care settings and community practices. So I leave you with a challenge as we move into some of our other sections. Is your pharmacy team ready to give the 2 vaccines that we see here? Are all of your patients that are eligible to receive these vaccines, are they vaccinated? If they're not, then let's move on and learn ways that we can boost those numbers. Now that we are more familiar with pneumococcal disease and our most vulnerable populations, we're now going to transition our discussion to the vaccines for pneumococcal infection. I put this slide in because I really want us as pharmacists to think and focus on pneumococcal vaccines for adults. There is a series of pneumococcal vaccines for our pediatric population, but that is not our focus in this particular presentation. Furthermore, our pediatricians do a very good job of vaccinating our young folks in the state of North Carolina and really across the country. Our goal is to maximize what you as pharmacists and pharmacy teams can do in your pharmacy setting and practice setting to maximize the number of pneumococcal vaccines you give to your adult patients every day. So before we look at the individual vaccines and how to administer those, I thought it would be nice to travel down a timeline and just look and see when the various pneumococcal vaccines came on the market. In 1977, we saw the creation of our PPSV 14, or our 14-valent pneumococcal polysaccharide vaccine. Then in 1983, PPSV 23 joined the pneumococcal vaccine family, or the 23-valent pneumococcal polysaccharide vaccine. In 2000, PCV 7 was created. It's the 7-valent pneumococcal conjugate vaccine. And then in 2010, PCV 13-valent pneumococcal conjugate vaccine came on the market. These dates will play a very crucial role in remembering when these vaccines came to market as we begin to talk about how do we distinguish which pneumococcal vaccine to give our patients. For example, we want to keep in mind that if patients state that they had the pneumococcal vaccine, quote, a long time ago, unquote, or it's been so long that I can't remember what I got, more than likely they received PPSV 23 and not PCV 13. On the other hand, if they state they know they had a pneumonia vaccine in just the last few years, then it really could be either one that they received. That's why reviewing patient medication profiles, vaccine registries, and age consideration is also important before administering a pneumococcal vaccine. Let's now dissect our two pneumococcal vaccines that we give our adult patients. On the left-hand side, you can see we're discussing PCV 13 or Prevnar 13. Again, this came out in 2010 by the Pfizer company. It contains 13 serotypes, and you can see them listed there. I do want to call your attention to the 6A that is bolded, because this strain here is what led the ACIP and CDC to decide possibly that our patients 65 years of age and older needed a vaccine that is PCV 13 after they turn 65. It is a conjugate vaccine. It comes in latex-free single-dose pre-filled syringes and is a quantity of 0.5 mLs. It is given IM only, and it must be gently shaken prior to administration because it is in a thicker component. This is also given to all infants in a 4-dose series, and you can see the ages listed here. However, our Pneumovax 23, or our PPSV 23, this was the one that came to the market in 1983 by Merck and Company. It contains 12 of the serotypes in PCV 13 plus an additional 13 serotypes, thus giving us the total serotypes it covered of 23. It is a non-conjugate, and it is supplied in a various forms of dose administrations, in particular multi-dose vial and single-dose vials and pre-filled syringes. It's also given intramuscularly or subcutaneously. However, pharmacists are trained to give this particular vaccine intramuscularly, as we will be covering later in our administration review, unless for some reason a patient cannot receive it IM. And this particular one is not indicated for children unless highly susceptible. These next 3 or 4 slides are taken directly from the CDC to enhance our understanding and hopefully break it out in an easy way to understand the segments and the sequence of administering our pneumococcal vaccines to our various patient populations. As you can see, this slide is devoted to those that fall in the category of age 65 years or older. As you can see at the top, it says if PCV 13 was given before age 65 years, no additional PCV 13 is needed. However, if a patient comes to you and you determine through registry checking verbal communication, possibly talking to primary care providers, and that goes into any scenario we're talking about. And this patient is pneumococcal vaccine naive, otherwise no history of pneumococcal vaccine can be seen. Then the ACIP recommends that they receive a PCV13 or Prevnar at that point, and then wait for 1 year, and they will then be able to receive a PPSV 23 or Pneumovax 23. Again, to review, that is if someone has never had a pneumococcal vaccine and they are otherwise healthy, they have just turned 65 years of age and they are older. If, however, they have received PPSV 23 before the age of 65, you do need to wait a minimum of 1 year. And I do want to say that this waiting of 1 year is primarily related to insurance billing, Medicare in particular. There are groups that we will see on the next slide and following that if there is a special immunocompromised situation, there is a progressive sequence that we can use that we'll see here in just a few moments. But I would encourage you to check with primary care physicians before employing anything that's sort of outside of these parameters. Again, if they received PPSV 23 before the age of 65, then wait 1 year and then give them a PCV 13. And then 1 year later, they receive another PPSV 23 if it's appropriate. There is the qualification of 8 weeks for groups B and C, as we'll see on the next slide, and 5 years after a prior dose of PPSV 23. If they received PPSV 23 at age 65 years of age and older, then wait 1 year and then they can receive the PCV 13. Again, this is for our patients ages 65 years of age and older. This takes us to our groups of chronically ill patients or those patients that are immunocompromised. If the patients are age 19 to 64 with underlying conditions, and let's take them as groups A, B, or C. In group A, we see that these are our smokers, long-term care resident facilities with residents, and chronic conditions like heart disease, lung disease, even liver disease. And here you can see that heart disease has excluded hypertension, lung disease has included asthma, and liver disease also includes cirrhosis. Here is our diabetes, and then alcoholism. They will receive a PPSV 23 or Pneumovax 23 at diagnosis or when you determine it's appropriate. In group B, this is our immunocompromised that also includes HIV infections or chronic renal failure, nephrotic syndrome, or asplenia. They will receive a PCV 13, 8 weeks later a PPSV 23, and then 5 years after that, another PPSV 23. And then finally, our group C is CSF leaks or cochlear implants. They receive a PCV 13. 8 weeks later, they receive a PPSV 23. I would suggest that pharmacists see more people initially in group A with the chronic conditions that we have highlighted here. If you see patients in groups B or C, then I would verify again with the primary care physician or any other healthcare providers that they might see to ensure that indeed the PCV 13 would be what they would need initially. Our next two slides also review for us another way of looking at these chronic conditions and special condition situations. Again, this, and I know this is hard to see, but I would suggest you going to the website, the CDC website that we have here at the bottom. And this is outlining what the CDC and ACIP considers as underlying medical conditions. And you can see the two columns over to the right with PCV 13 recommended and PPSV 23 recommended. I'm going to talk about this more later, but I still contend that it's in these special populations, especially immunocompromised situations, where we as pharmacists and even other healthcare providers get confused. We just don't know simply what is to be given to them. And I just think this chart and the one that I'm going to show you here in just a moment represent another way to distinguish whether the patient should receive PCV13 or PPSV23. It also points out revaccination recommendations as well. I used to keep this chart in my counseling room as a check prior to administering a pneumococcal vaccine. It can be found on the CDC website using the web address on the slide, as I mentioned to you. And then here is the underlying medical condition blown up for your reading so that you can see where PCV13 or Prevnar is recommended. Okay, let's move on to contraindications and precautions to pneumococcal vaccination. And the beautiful thing is, fortunately, there are very few contraindications other than the expected when giving IM vaccines, such as the one we'll discuss here in just a moment. Please note that PCV13 does contain a tetanus protein in it and should be used with caution in patients that state a tetanus reaction. Please always spend the extra 15 to 20 seconds explaining to patients about potential localized reactions. We never want them to go home and later call to say their arm is red and feverish and we never told them. Also, if they state on their consent form that they had prior reactions to any component of the vaccines or have had injection site reactions in the past, just make sure they know what to expect. Here are just some clinical pearls that I think are also helpful. Please be encouraged that it is better to vaccinate with the same vaccine than to not vaccinate at all. That's sort of our standard of practice, right? But now that North Carolina pharmacists can use the Immunization Registry, we are slowly but surely building the adult vaccine base. And it's not perfect since all healthcare providers don't and aren't required to use it yet. But it does sort of help this navigation of especially pneumococcal vaccines a little bit easier, although we still get incomplete vaccination records. So if you find that there's no record of vaccination of either PCV13 or PPSV23, then go ahead and revaccinate. And depending on what category they fall in, obviously they will determine which one you give first. And just keep in mind, PCV13 has only been available since 2010, and Medicare should pay for one of each vaccine after the age of 65. And in my past couple of years of practice, I have seen Medicare do hard stops when billing for either PCV13 or PPSV23 if they can find another claim. Again, still not perfect, but at least we've gotten that straightened out. Okay, these next few slides are just going to be a recap of indications. We've got PPSV23. This just tells you everything that we've already talked about. You can see the asthma here, smokers, chronic illness. And then for our recap of PCV13, routine vaccination in our children for 65 years of age and older, and one dose 19 to 64 years of age for the unique special cases that we've discussed. Now let's transition to a few patient cases. I will read the question slowly, pause for a brief moment to give you an opportunity to think about your answer, then reveal the correct response. Here we go. Diane is a 24-year-old with type 2 diabetes. She is picking up her insulin pen and wants to know if there are any vaccines that she needs today. What are your recommendations per ACIP guidelines? Did you guess letter A, Pneumovax 23? Patient case number 2. You receive a call from a physician with a pneumonia vaccine recommendation for one of her patients. The patient is 60 years of age, has diabetes, and has a record of receiving the pneumonia vaccine 3 years ago. What is your recommendation? Hopefully, we all chose letter C. And just to clarify, we don't know what she might have had. So before we give her a vaccine, we need to make sure, we need to do as much homework as we can to determine what she might need before administering any. Our final case is, what would your recommendation be if this same patient was 66 years of age? Did you guess Prevnar 13? This patient seems to be vaccine naive to pneumococcal vaccines. Therefore, CDC recommends that we give Prevnar 13 to this patient. I hope you enjoyed these 3 patient cases. Moving on, I want you to remember my stop sign in your head prior to giving any pneumococcal vaccine. Please stop and look to see what vaccine you are giving to your patient, especially if it relates to pneumococcal disease in prevention. Is it the correct one? If you are giving a pneumococcal vaccine to your patient and they are less than 65, more than likely it should be PPSV23. If you think it should be PCV13, then please stop and ask yourself, why are you giving that particular vaccine? Remember my stop sign. Okay, it is now time to transition to one of our additional sections of our program, vaccine strategies. I wish the data supported that since pharmacists have been vaccinating, that there has been a tremendous increase in the number of vaccines of all types being given. Unfortunately, that is not the case. Suffice it to say that there is still much to be done to increase our patients' vaccine numbers, especially in the area of pneumococcal disease, and particularly focusing on those areas of chronic diseases that we have mentioned earlier in our presentation: diabetes, chronic heart disease, and chronic lung disease. Currently, we are at a national average of less than 20% nationwide in being able to vaccinate these chronic illnesses. I would suggest that it is with these 3 disease states that pharmacists can strive to make a tremendous difference. Let's review some ideas and strategies to help us do that. As you can see here, these are some suggestions to increase pneumococcal vaccine rates. Because it is difficult to do all that is required to do in day-to-day pharmacy practice, here are 4 suggestions on how pharmacists can help increase the number of pneumococcal vaccines that they give and possibly help streamline that process. I do want to mention that we still have many patients that are turning 65 every day that come to our pharmacies. It is certainly worth running annual reports to see if they are eligible for pneumococcal vaccines, and then go ahead and administer to those patients. Also, as we mentioned earlier, focusing on those patients between the ages of 19 and 64 years of age with diabetes, chronic heart, and chronic lung disease. Then we're going to develop our 4 Pillars Toolkit. And our final strategy is to consider implementing the CDC best practice standards for adult vaccination. I wanted to show you some percentage of effectiveness for patients 19 to 64 years of age with our chronic conditions. This slide demonstrates why the CDC recommends PPSV23 in our chronic disease patients at the time of diagnosis. We can see since 1997 that ACIP has specifically recommended this vaccine because in diabetes alone, it shows an 84% effectiveness against pneumococcal disease. In chronic lung disease, in particular COPD, there's a 65% effectiveness. And with chronic heart disease, there's a 69% with CHF or congestive heart failure, and coronary vascular disease shows a 73% effectiveness. So what is our 4 Pillars Toolkit? This is another strategy to enhance our vaccination rates, and this kit is described in various papers as a practice transformation method when employed. It contains these 4 pillars of operation. So we look at enhancing access and convenience to our vaccines, looking at how do we communicate with patients about vaccines? What do we say to them? Oftentimes they're going to listen to a pharmacist before they even listen to another healthcare provider in giving or in allowing us to administer a vaccines. Enhanced vaccination systems. What do we mean by that? And then just looking in particular at motivation, whether it's our patients or whether it's our pharmacy teams. Let's consider access and convenience. We already know that pharmacies, especially outpatient pharmacies, oftentimes have longer hours than many of our healthcare providers, for example, doctor's offices or ambulatory care clinics. We need to use all opportunities to vaccinate, and especially flu season. We need to offer all eligible vaccines when flu season is in season. And this especially includes pneumococcal vaccines. And we also want to consider implementing express vaccination services. I'm sure many of you listening and watching this already do vaccine clinics at off-site locations, for example, helping the school system or various employers in your various locations. We've talked about convenient hours, and I would also suggest trying to have a dedicated technician to assist you with this, because having a dedicated technician, and we will name this dedicated technician, much of this, with the exception of actually doing the administration, much of this process can be done by your technicians. What about patient communication in our 4 Pillars Toolkit? How do we communicate? Well, one of the things that we can do, and many of us, especially in outpatient pharmacy, are probably already doing MTMs through the various platforms that are available, but just attaching a review of the medication record every time a patient comes in to pick up a new prescription, either for a new one or a refill, and attaching their medication record to them, looking and doing a brief history search on the Immunization Registry to see what the patient has or has not received, checking the Immunization Registry for vaccine history as we talked, discussing serious consequences of not receiving pneumococcal vaccines. Many times it's just sending the patient on the other side to say, do you want to get pneumococcal disease? Did you know it can cause bacteremia? Did you know it can cause meningitis? And encouraging patients to receive as many vaccines as possible during influenza season. This was always my go-to with employee health screenings, is I had them captive from July until September, and my flu vaccine would come, very close to the end of July or the 1st of August. And if those patients qualified, my smokers, my folks with asthma, if those patients qualified, I was known as the mean old lady pharmacist that would put 4 needles in their arms a lot of times. It would be flu and shingles vaccine if they were eligible, pneumococcal if they were eligible, and then their Tdap if they needed an update on that. So encouraging that and having the conversation with them. They were usually not mad at me, but for about 24 hours. Vaccine systems. Utilizing the vaccine registry with every visit if it's appropriate. Ensuring that proper documentation to both the registry and physicians' offices are sent where they need to be. And we'll be covering that a little bit more in the law and regulatory section. Employing EHRs when possible. This is where inpatient and ambulatory care clinics, I think, are better equipped to serve their patients than those of us that work in the outpatient. Because with electronic healthcare records, you have access to you should have access to their vaccine records as well. And using your dispensing system for reminders and alarms if a pneumococcal vaccine is needed. And then our final pillar in this toolkit is the motivation. we can set vaccination goals with our pharmacy teams and supplying motivation to increase those pneumococcal vaccination numbers. This is where your technician can come in by creating an immunization champion to maintain motivation within the pharmacy team and with patients. And then making sure all of your appropriate and eligible employees are vaccinated with pneumococcal vaccine. And the CDC standards, which is our final vaccine strategy for adult vaccination, it revisits some of the stuff that we've already discussed. I'll just review them once again. But assessing vaccination status of all adults at every pharmacy counter, we mentioned that already. And then recommending the vaccines that are clearly indicated. Administer the needed vaccines and get prescriptions for those that can't be administered under protocol. So I would caution us in North Carolina to make sure that looking at the ages of those that you're vaccinating, again, we're going to review our standards of practice, our best practices for North Carolina immunization practice here in just a moment. And then we need to make sure that we are documenting the vaccines received by the patient and report those accordingly. The purpose of these strategies is to offer any method possible that each of us can adapt to our current practice site that will increase not just pneumococcal vaccine rates, but all vaccines. It is in the best interest of our patients and public health to strive for 100% vaccination rates in our pharmacies. Now that we have discussed the pneumococcal disease process and the vaccines to help prevent it, I do think it's important for us to spend just a little bit of time reviewing basic immunization practice requirements for those of us pharmacists, for those pharmacists in North Carolina. All of this should be a review for anyone listening that gives vaccines regularly, of course, but it never hurts to remind ourselves of best practice and expectations. I'm going to move through this section, though, fairly rapidly, so hang with me. This slide just reminds us of what our requirements are to be an North Carolina immunizing pharmacist. I do want to point out that we need to make sure that our CPR, provider level CPR, is kept current. I think American Heart is every 2 years. Most of us do that. American Red Cross, I think, is once a year. And if you use any other type of CPR certification program, just make sure your CPR stays up to date. And any of us listening here, if we're vaccinating regularly, we've completed our certificate program. I also want to remind us that we do need to do yearly OSHA bloodborne pathogen training and have a means of doing that, and needle stick safety precautions. It is required. And then one of our final points is to just remember that we do need to keep on record and achieve 3 hours of immunization-related continuing education every 2 years. I want to remind us, too, what does our North Carolina Immunizing Rule say according to the Board of Pharmacy? It reminds us that under protocol, patients 18 years of age and older, with the exception of patients 14 years of age and older for flu, these following vaccines can be given on protocol: pneumococcal, meningococcal, hepatitis B, the tetanus, diphtheria, and pertussis containing vaccines, and our herpes zoster vaccines. But we all also are allowed the freedom of giving with prescriptions any CDC recommended vaccines to patients 18 years of age and older, with the exception of yellow fever. I do want to remind us that if we're not doing this already, to report any immunizations administered to their primary care provider, to the patient's primary care provider, within 72 hours of administration. We also need to make sure that we access the North Carolina Immunization Registry prior to administration to make sure that we're not duplicating vaccines, because if the vaccine is listed in the registry and we do not access that prior to giving it to the patient, and we duplicate that vaccine, that is considered a misfill or a duplicated vaccine. And this all has to be, and then it has to be reported to the NCIR within 72 hours. And then we also are supposed to be using a minimum standard screening criteria for written protocols that was developed by our state jointly by North Carolina Healthcare Coalitions. What does that look like? Here are the minimum screening criteria. You can find this on the Board of Pharmacy. I do want to call our attention in particularly to question number 4. Has any physician or other healthcare professional cautioned or warned you about receiving certain vaccines or receiving vaccines outside of a medical setting? And then moving to screen number 2, question number 14, as related to tetanus-containing vaccines. Do you have a cut, injury, puncture, or open wound that prompted you to get a tetanus shot? But these are listed on the website, the Board of Pharmacy. They have been jointly described, and if these are not on your current protocol screening questionnaires, I would advise you to revise them and make sure they are on there. Moving along, this document just represents what pharmacists are supposed to give a patient that wants a vaccine, and they do not state or list a primary care physician. You can see the website at the bottom. This comes off of the Academy of Family Physicians website. It's www.ncfamilydoctor.org, and we do need to be giving these out. This is just a slide reminding us of the Immunization Registry. It is a public health database, not a pharmacy database. It registers pharmacies, not pharmacists. I have had questions asked of me about the registry related to that. And keep in mind, still all vaccines except influenza need to be recorded in the registry. If you are not currently doing so, I would in all of our spare time. All past and current vaccines should be entered under the Historical Vaccines tab within the patient's registry profile. You do need to have emergency procedures and follow them accordingly. We've talked about properly screening and questioning and making sure patients understand the side effects of said vaccine, in particular the pneumococcal vaccines. We want to remind patients with pneumococcal vaccines, both Prevnar and Pneumovax, have a tendency to cause a little bit more redness, a little bit more pain. So just keep that in mind. You also want to make sure you know how to handle any potential anaphylactic reactions, and then a written protocol that includes epinephrine and diphenhydramine. Make sure that you give your patients the vaccine information statement. These can be printed off of immunize.org or ACIP or CDC, and make sure patients read these prior to receiving their vaccine. And if you do encounter adverse events, they have to be recorded and reported to the Vaccine Adverse Event Reporting System, or VAERS, by the immunizer. And in some cases, especially in corporate situations, they're also treated not as a misfill, but we used to treat adverse events as we would use our same documentation and just make sure it was documented as an adverse event, just so that there was a company paper trail as well. I just wanted to share with you, this is the Vaccine Adverse Event Reporting System. Here's the website. The left side picture is the homepage for VAERS, and then on the right side you see where you are supposed to go in and report an adverse event online. This slide represents the ISMP National Vaccine Errors Reporting Program. This, you can see there is another website for it. It's called BURP. This you use if the wrong dose of a particular vaccine was given. Not necessarily an adverse event, but if the wrong dose was given, if a wrong vaccine. You can see there's various things that you would report to this one, but this one's not used as much simply because I think pharmacists and other healthcare providers don't realize it's out there. Okay, transitioning really quickly to additional information. Here is some additional information we just need to always keep in mind when giving vaccines. We have general adverse events. There are those from inactivated vaccines, of course. Both of our pneumococcal vaccines are inactivated vaccines and live attenuated vaccines. Make sure this is communicated to your patients. Because we are giving flu and pneumococcal vaccines often at the same time, there is no minimal interval for those two vaccines. I will let you read on your own the minimal interviews of other situations. Though temperature logs are not required, they do represent a best practice model. I did want to include this because a temperature record comes in handy, especially if something happens to the storage facility that you use due to outages or other mechanical problems. And oftentimes products can be saved if there is a method to track temperature. So I just wanted to include this. I can't tell you how many times I have been able to track a product, not just vaccines even, just drug product alone, and be able to provide this to the manufacturer, and they have been able to save our product. So I just wanted to include this. I've got two slides related to pharmacy technicians because I know that I could not work in my pharmacy without them. I could not do my job without them. So I just wanted to revisit them and encourage you to think about immunization champions with your pharmacy technicians. A lead technician can serve in that role for you, and in many cases, oftentimes my patients wanted to talk to my techs before even talking to me. And they are, in my opinion, the administrative experts of the pharmacy, especially for billing and maintenance of inventory and other workflow processes. So they were invaluable to me in our pharmacies where vaccinations were concerned. And I've got just an outline of the various responsibilities they could be given. And in fact, our pharmacy technicians knew that if a patient came up, that they were to keep the NCIR right before them at all times. And then they would oftentimes enter the vaccines for us. This is just a list of the resources that I use all the time. You can see Center for Disease Control, IAC, or Immunization Action Coalition, American Pharmacists Association, the Board of Pharmacy, and the Registry. We've talked about that. Our last section I do want to spend a little bit more time on. I do know that we are about out of time, but I feel like it's important for us to review appropriate intramuscular technique. I believe it's imperative that we review this every so often. I know in the company that I used to work for, we started doing technique administration review every 2 years. And I think it's important, especially in light of some data that I'm going to be sharing with you in the next couple of slides. It's easy to get very sloppy, I think, in our comfort zone of being able to give vaccines. But just as we don't ever get sloppy in the way we operate our pharmacies or talk to patients about medications, I would suggest we don't need to get sloppy in our vaccine administration technique either. Every patient needs to be treated as our best. So why am I discussing this? Well, let's look at some shoulder injury data. Between the 2007 and the 2013 flu seasons, reports to VAERS indicated shoulder dysfunctions. During this period, around 130 million doses of inactivated influenza virus were distributed across the country. There were a higher percentage of reports of shoulder dysfunction following inactivated influenza vaccine among females when compared to non-shoulder dysfunction reports. And you can see the report that's listed out of vaccine in 2016. So this was published in 2016. Here's what I wanted you to see though. 70% of these reports were in the age group 19 to 59 years of age. When possible contributing factors were described, vaccination was given too high in the arm. This was the most commonly reported error. And unfortunately, the most common place of vaccination documented in the reports was either in pharmacies or drugstores or doctors' offices and hospitals. Now, the report does not go on to differentiate what percentage of these reports were pharmacies and drugstores or doctors' offices and hospitals. So we don't know in that 70%, what percentage of those, were there more given in pharmacies and drugstores or more injuries from doctors' offices and hospitals? So unfortunately, it doesn't break it down that far. But suffice it to say, I think we need, because we have become a primary vaccinating healthcare group of individuals, I think it's important that we know that this study has been done. So this slide just helps us remember where we need to give an IM vaccine. So if you will look at both of these pictures, nowhere do you see the needle anywhere close to the bursa or the shoulder area where there is a ton of nerve endings. I would almost suggest that I would rather see you give it lower in the deltoid than higher in the deltoid if there is any doubt in your mind whatsoever where to administer it. Do not, please, do not give it any higher than you see in either one of these pictures here. Also, if you are going to give a flu and pneumonia vaccine or any other vaccine in the same arm, make sure that these vaccines are separated by at least 1 inch. So it would be very easy to detect which vaccine was given where, and make sure that is documented very clearly on your consent form. Moving from administration, I want to point out that on a final note, this slide refers to the best practices that the CDC has now started offering on its website for immunization practice. It's called You Call the Shots, and you can see the web address located at the bottom of this slide. It does have continuing education attached to it, with many of its videos containing useful information. And there's also a video on there about administration technique. However, in the recognizing the limited amount of time that we had for this hour-long program, I did not want to show the video in this particular program. This is my reference slide. I also want to point out that I love this quote. It's not original with me, but I do want to leave this as a final thought. Vaccines do not save lives. Vaccinations save lives. I also want to give special thanks to Anna Armstrong. She helped with some of the reviewing of this material. It has been a pleasure providing this pneumococcal update to all of you. I also want to encourage you as you go about your day-to-day practice and knowing that you have many opportunities to vaccinate, keep in mind that our patients that need pneumococcal vaccines, especially those with chronic conditions, diabetes, chronic heart, chronic lung, need to be vaccinated. In this particular category of patients, it is less than 20% across the country where these patients have been vaccinated with the appropriate pneumococcal vaccine. Take every opportunity you can to provide the appropriate pneumococcal vaccine sequence to these patients. And as always, it has been a pleasure talking with you. Thank you so much for joining me for this NCAP collaborative on pneumococcal vaccines in practice. My name is Ouita Gatton, and my final point is to receive continuing education, follow the directions on the North Carolina Association of Pharmacists webpage for this webinar. Thank you and good evening.